So as we know, medicine is not only science, it is an art of taking the history and examining the patient properly. And that is why we have to know properly what to ask and what to see in the patient, and that will all depend on what you are suspecting in that patient. So when we go now, today we are going, now I'm going to discuss history and examination. So classically in our MBBS days we have learned this history taking, and it involves history regarding the illness. In this case it will be type of diabetes, duration of disease, presence of other complications, and the diabetes education level of the patient, the personal history, the family history, and the social history. Now all this history is important in patient with diabetic foot ulcer. So when we go about the presenting complaint, the complaint can be skin breakdown or ulcer. There may be edema, change in color of the skin, pain, discomfort, or abnormal sensations. So if we ask specifically for edema or any other problem, ulcer, we have to ask when is the problem, where did it start, how many days, if there was any incident, how it started, what makes it better, what makes it worse, and has it been treated earlier? If yes, how? Again, with regards to pain, from when did it start, how did it start, where is the pain, what is the nature of the pain, whether it is a burning pain or shooting pain, what aggravates the pain, what relieves the pain, when does it occur, and what are the treatment given again. So all this history is very important. Why is it important to ask the specific history about the pain? Because as we know, we want to look whether there is neuropathy which is predominant, whether there is ischemia which is predominant, and that is why the history of pain will be important to differentiate between the two. Also we can ask whether there is history of slipping of chappals. If the patient may not be feeling pain, but patient will tell you, yes, sometimes it happens, I walk ahead, and then you realize that he has slipped off his chappals. So all that is the history which you have to ask to the patient. Now regarding the pain, if it is a pain due to neuropathy, it will be burning pain. There may be contact discomfort in both the feet and the lower leg, which may also involve the thighs. There may be sharp shooting or lightning pain like symptom. It is relieved by cold. It may be worsened during period of rest. Unilateral burning pain with muscle wasting may be seen in focal neuropathy. And if there is pain due to ischemia, what will happen? There is a persistent pain which worsens on elevation and is relieved by dependency. There is pain in calf on exercise, which is again relieved by rest. The claudication may be often absent in ischemia because of neuropathy. So even if there is pain, because of neuropathy, the patient will not perceive the pain. So that is another thing we have to keep in mind. Now this is the history regarding the present complaint. Then we go to the past medical history and the foot history. It is important to know the duration of diabetes, the presence of any other comorbid complications like retinopathy or nephropathy which is present, the other serious illnesses like rheumatoid arthritis or cancer, or patient is on any immunosuppressant agents, history of accidents, injuries, hospital admissions, allergies to any other medicines, previous ulcers and Charcot's arthropathy, whether there was history of major amputation, minor amputation in the past, peripheral angioplasties and arterial bypasses. Sometimes the patient may not directly tell you that I have done this first. He will just come with the presenting complaint, but it is very important to ask whether there was any other similar history in the past. Family history and psychosocial history is also important. Family history of diabetes, other serious illnesses in the family, psychosocial history, whether the patient what kind of job the patient is doing, if patient is walking barefoot, has history of repeated putting the feet in the water. The religious beliefs are also important. There are people who walk barefoot to the temples or certain religious norms that they keep on carrying out. Then the addiction, smoking is also an important risk factor for PVD. Psychiatric illnesses, drugs or alcohol dependence is important. The home circumstances are also important. The type of accommodation where the patient is living. Is there anybody who's going to look after the patient? Because elderly patients may not be able to even see their feet or cut the nails or see what is the problem. So whether he is living alone or whether there is any support. Even when we want to manage diabetic patient, we want offloading. during that time there has to be somebody who is taking care of the patient, because otherwise it will be very difficult for the patient to manage. So we should understand the patient, the problem that the patient is facing. Just prescribing anything or advising anything to the patient is not enough. You have to understand his problem, only then we will be able to manage it well. Now after understanding the history, it is very important what examination. Now eyes will see what mind knows. So what you have to see, that first you should know what are you looking for. You cannot just do a routine examination, especially specifically for diabetic foot ulcers. So the comprehensive foot examination will involve inspection, palpation of dorsalis pedis and posterior tibial pulses, patellar and Achilles reflexes, and determination of proprioception, vibration and monofilament sensation. Now, the foot examination can be done by a physician or a nurse or any trained staff. It can be done very quickly in 30 seconds. You have to inspect the foot between the toes, from the toe to the heel. Complete foot examination is necessary. Tell the patient to remove the shoes as well as the socks. Inspect the shoes and the socks both. Look for the discharges in the socks or the fit of the shoe, or whether the shoe is ill-fitting, or whether there is any nail or foreign body inside the shoe, which is important. Then examine the skin, look for injuries, calluses, blisters, fissures, ulcers or any other unusual conditions. Look for the thin, fragile skin and hairless skin. These are the signs of less blood supply of the skin. Remove any nail polish and inspect the nail for thickening and ingrowing of the nail, because that is the first cause where the abscess starts. And look for the musculoskeletal deformities or Charcot's arthropathy. Again, clinical examination will involve palpation of pedal pulses, tibialis and dorsalis pedis both has to be palpated. There may be around 6% people who may not have dorsalis pedis unilaterally or bilaterally. So to understand during the examination assessment of neuropathy, we have to see the symptoms such as tingling or pain in the lower limb, especially at the night, pressure perception using Siemens-Winston monofilament, vibration perception using 128 Hz tuning fork, pain discrimination using pinprick, tactile sensation using cotton wool, and Achilles tendon reflexes are to be checked. These are the diagnostic instruments which have to be present in our clinic: the hammer, the measuring tape, monofilament wire, tuning fork. So which tuning fork are we going to use in this patient? 128 Hz. The 5 and 2 Hz frequency is used for Weber's. Yeah. So now when we say the sensory foot examination, the 10 gram monofilament is used, and the sensory examination is carried out in a quiet setting. First, apply the monofilament to the patient's hand, and patient has to understand how it feels. And then when you are examining the patient's eyes has to be closed. He is not supposed to see. These are the 4 sites where you have to test. It has to be in an asymmetric manner, so that patient will not know when you are going to go where. Apply the monofilament perpendicular to the skin, sufficient force to cause the filament to bend or buckle, and total duration of approach, the skin contact and the removal should be approximately 2 seconds. Apply the filament along the perimeter of, not on the ulcer site, calluses, scars or necrotic tissue. And when we perform this on 4 times in each foot, and so total there will be 8 stimulus, and the score of 0 if it is not perceived, 0.5 if it is lesser than in the hand, and 1 if it is same. So if the score is 3 out of 8 correct responses, means the presence of neuropathy is likely. The loss of sensation over the distal plantar surface to the 10 gram monofilament is the significant and independent predictor of foot ulceration and lower limb amputation. The gangrene will prevent the ulceration, will cause, the PVD will cause gangrene, but the cause of ulceration is going to be neuropathy. So, and this is the test which is going to identify the patient who has diabetic neuropathy. So this is how we have to see. This is the bend. Only this much force has to be applied so that the monofilament bends. Now, the negative predictive value is almost 90 to 98%. That is only small percentage of patient who feels the monofilament, are likely to develop foot ulcer, whereas a positive predictive value is going to be 18 to 36%. Again, this is superior to the pinprick and the tuning fork also. Now, this monofilament can be used for say 100 times, and if it is bent, it has to be replaced. While asking the patient, you have to tell, I mean, patient has to close the eyes, and then you don't have to ask a direct question whether you're feeling it. You have to tell the patient that you let me know when you feel and whether it is same or different. If you ask, it is becoming a direct question and patient may answer, or there may be a false answer also from the patient. Or sometimes you can just not touch and ask the patient whether you are feeling it, and you will understand whether the patient is actually feeling or not feeling it. This is the monofilament testing. Then the vibration perception, which can be checked by 128 hertz tuning fork, or we can use this biothesiometer to analyze the vibration sense also. Then another thing which we are also worried about is motor neuropathy. What happens because of motor neuropathy? There is high medial longitudinal arch, atrophy of the small muscles, foot drop, and abnormal gait. And what will happen because of the motor neuropathy? The intrinsic muscles is lost, and that is why you may have deformities like this, which is hammer toe, claw toe, hallus valgus, or Charcot's foot. Of course, we have the entire session, next session, which is going to be on the Charcot's. And the pressure points can be seen in this Harris mat. Patient keeps the steps on the ink mat and walks on the long sheet of paper, and then the footprints are analyzed with respect to pressure points. The autonomic neuropathy is assessed by the presence of dry skin or fissuring and the distended veins. Now, pre-ulcerous cutaneous pathology will be neuropathy along with inappropriate footwear, presence of arrhythmia or callus with subcutaneous hemorrhage. Also, the presence of fissure will lead to ulceration or augment the callus formation. And poor self-care of the feet is also important. Interdigital maceration with fungal infections and nail pathology, all this will predispose the patient to ulcer. So these are this is what we should look for. The erythema on the first metatarsal joint, and the ingrowing toenail with the fungal infection. This is the thick skin. So this is all what we have to look for. These are the pre-ulcerous stages. Now, after discussing neuropathy, the peripheral arterial disease, again the prevalence is of PAD, which is measured by ankle brachial index of less than 0.9. The prevalence is almost 20 to 30%, and the complications include claudication and functional disability. Also, when the patient has PAD, there is increased risk of concurrent coronary artery disease and cerebrovascular disease also. It delays the ulcer healing and it increases the amputation risk, but it does not increase the risk of foot ulcer. Once the ulcer is developed, it increases the risk of non-healing and amputation. So what are the points in history which will help us in identifying the peripheral arterial disease? The pain. If the patient is not able to walk less than 1 block, it is suggestive of severe ischemia. If the pain is on buttocks and thighs, the block is at iotoiliac level. If the pain is in calf, femoral block, and foot or ankle pain suggests a tibioperoneal block. The rest pain indicates a critical ischemia, and there may be pain, toes and forefoot pain may be present, and it may be difficult to differentiate from neuropathic pain. Again, the clinical examination we need to do is peripheral pulses, but absent dorsalis pedis and posterior tibial, both. If both are absent, the likelihood ratio of developing peripheral artery disease is 3 to 3.8, which is very high. But if either one is absent, it does not predict PAD. And similarly, presence of both the pulses does not rule out the arterial disease also. So to evaluate the peripheral vascular status, we can do a ankle brachial index evaluation. So measuring the BP at the ankle level and the high arm pressure and the ratio of both this, which gives us ankle brachial index. Normal more than 1.3. Normal is between 0.9 and 1.3. More than 1.3 means there is medial calcification and therefore the vessels are non-compressible. If the ratio is between 0.4 to 0.9, it is mild to moderate PAD, and less than 0.40 is severe PAD. Again, along with ankle brachial index, we can also do a Doppler flow meter, which helps us to know the flow in the peripheral artery. Even this is what I've already discussed. There is a poor ulcer healing if the ABI is less than 0.5. Even the toe brachial pressure is also measured, because as we discussed earlier, the small arteries are also involved, and therefore it is important to measure a toe brachial index also. So these are the various tests we can do. First, see the pulses, then do an ABI, then even toe brachial index. There is transcutaneous oxygen perfusion also, which we can test. After that, sonography. If still we are not at diagnosis or don't know the level or the how much block is there, we can do an angio or even DSA or CT, whatever is required accordingly. So after this is a specific foot examination, but we also have to see the general examination, look for cardiovascular, respiratory system, abdominal, and the eyes. Eyes are important because if the patient is having neuropathy or a PAD, there is likelihood that the patient will also be having retinopathy. So we have to look for that also. The other investigations, as we discussed already, the neurological vascular investigations and the clinical examination that we have to do for foot pressures and the radiological test. The lab test will include the routine RFT, LFT, HbA1c, because level of blood sugar control is also important. CRP, CBC also. Then X-ray foot is done if there is osteomyelitis or Charcot's foot. Those are the two indications for X-ray of the foot. So to summarize how to perform a proper quick foot examination, what are we looking for? Whether there is neuropathy, whether there is ischemia and infection. So 3 points you have to look in. Ask the history accordingly and do the examination accordingly. Look for structural abnormalities like skin changes, evidence of infection, callus or ulcers, range of motion of the joints you have to check, and presence of Charcot's foot. Peripheral arterial assessment can be done by palping peripheral pulses, temperature and skin changes, and measuring the ABI. Neuropathy assessment is done by 10 gram monofilament. After identifying the patient, it is important to categorize the risk. There is a risk score again, which after me Dr. Abhijit is going to cover. So I'm not going into detail of that. But the regular inspection and examination of at-risk foot is necessary. Similarly, education of the patient, family and the healthcare provider is needed. Routine wearing of appropriate footwear is the must at home as well as at work. And treatment of pre-ulcerative signs are very important in preventing foot ulcers and hence amputations in longer run. Thank you.